Morning. My name is Dr. Jaime Merchan. I'm a professor of medicine and a medical oncologist at the Sylvester Comprehensive Cancer Center at the University of Miami School of Medicine in Miami, Florida. LITESPARK-003 is an open-label phase 2 study investigating the activity and the safety of the combination of belzutifan, a novel hypoxia-inducible factor alpha blocker, and cabozantinib, an anti-angiogenic tyrosine kinase inhibitor. The study consists of two arms. Cohort 1, which is the one that I presented at ESMO, involved patients with treatment-naive clear cell renal cell carcinoma with a good performance status of ECOG 0 to 1 and measurable disease by RECIST. Cohort 2 involved patients previously treated with immunotherapy-based combinations. Cohort 1, which is the one that I presented, the preliminary results, involved up to 50 patients to be enrolled, and at the time of the presentation, we had enrolled 35 out of the 50. The patient population was a typical patient population for renal cell carcinoma. The median age was 64 years. Most patients were men, and the majority of patients have a very good to excellent performance status, like ECOG 0 in 60% and ECOG 1 in about 40%. And also the majority of patients, 60% of them, belong to the IMDC favorable risk group, while 40% were in the intermediate to poor. The primary endpoint of the study was objective response rate assessed by investigator. And we observed a very promising and high overall response rate of 57%. 20 out of 35 patients had RECIST defined criteria for a partial response. 13 patients or 37% had stable disease, and the disease control rate was 94%. It was important to notice also that no patients had a progressive disease reported as best response. And the responses that we saw occurred along all IMDC risk categories, both in the good, intermediate, and poor risk. And the responses were deep, meaning that many of them, the percent decrease in the target lesions was significant and prolonged. The time to see the antitumor effects that we call a median time to response was short. It was 1.9 months. And the duration of response, the median duration of response, was 28.6 months, with a median progression-free survival of 30.3 months. Overall survival was not reached. However, the 12-month survival rate in this cohort was 96%. Finally, in terms of adverse events, the most common adverse events that were seen of all grades included anemia and diarrhea in 71% of patients and fatigue in 63%. And the most common grade 3 adverse events included hypertension in 11% and fatigue in 9%. We did not see any grade 4 or 5 treatment-related adverse events. So anemia and hypoxia were two what we call adverse events of special interest because they are related to belzutifan, which targets hypoxia-inducible factor 2 alpha. Anemia was observed in 71% of the patients, and hypoxia was less frequent, occurring 6%. In conclusion, the interim results of cohort 1 of the LITESPARK-003 that involved patients with treatment-naive clear cell renal cell carcinoma showed a very high and promising response rate of 57% with 2 complete responses, and all patients had reductions in the size of the target lesions. No patients had progressive disease as best response, and safety-wise, we did not observe any concerning signals of safety. The scientific rationale for combining belzutifan, which is a potent and selective small molecule HIF-2 alpha inhibitor, and cabozantinib, a multikinase inhibitor that targets VEGF and other receptors, is based on the fact that clear cell renal cell carcinoma is associated with VHL silencing in the majority of cases, which leads to HIF-2 alpha accumulation, and this leads to further angiogenesis. When we start patients on anti-VEGF tyrosine kinase inhibitors, even though patients have an initial response, they develop resistance, mostly based on the development of tumor hypoxia, which leads to further HIF activation. Therefore, combining an anti-VEGF agent with a HIF-2 blocker, in our opinion, it may provide improved anti-tumor responses and outcomes compared to monotherapy. Anemia is what we call an on-target side effect of belzutifan. And the reason for that is because HIF-2 alpha upregulates erythropoietin expression, and therefore blocking HIF-2 alpha causes rapid reduction in erythropoietin, which may lead to anemia. We saw anemia in 25 out of 35 patients, or 71%, and 2 patients had grade 3. The anemia was mostly grade 1 and 2. It was mild, and most of the patients who had anemia that required treatment were managed with supportive measures such as erythropoiesis-stimulating agents. And one of the patients with grade 3 anemia required blood transfusion. So I don't see anemia as a major limiting factor in the use or the development of these agents. Now, another adverse event of special interest is hypoxia, whose mechanisms are not well established. It is rare. In our study, in patients in cohort 1, we saw it in 6% of the patients, and one patient, or 3%, had a grade 3 event, and hypoxia was managed with supplemental oxygen. And in one patient, and in another patient with grade 3, we had a dose reduction. So I do not see any other very concerning adverse events from belzutifan other than these two, which are the ones of special interest. For the first question, the answer is yes. There's currently a randomized phase 3 trial for patients in the first-line setting investigating the triplet combination of belzutifan, lenvatinib, and pembrolizumab. Okay, there are other trials that are investigator-initiated, which are trying other belzutifan combinations, but the combination with immunotherapy, especially the triplet, is of special interest and highly promising. So we hope to see much higher complete response rates. And because the adverse events are non-overlapping, we do not expect additional toxicity. In regards to arm 2 of the LITESPARK-003, this arm involved patients previously treated with immunotherapies. The results were presented at ESMO also by David McDermott in a poster presentation, and it also showed very promising activity of about 31% response rate in patients previously treated with immunotherapy and immunotherapy-based combinations. Those are two different patient populations, first line versus previously treated. So I'm not sure we can really make comparisons or assumptions between one or the other arms. I believe that belzutifan probably, based on the response that we saw in the first line, may have a role in the first line setting, and obviously it warrants further investigation. Yes, this is a very interesting topic, the role of cytoreductive nephrectomy after initiating systemic therapy. This is being investigated in clinical trials, okay? In the case of belzutifan-based combinations, either with a TKI alone or a TKI immunotherapy, in my opinion, there may be a role of a cytoreductive nephrectomy in patients who have outstanding responses and the primary tumor is still in place. There is some observations, even in first-line trials, that many systemic therapies and combinations have excellent activity against metastatic lesions and less significant anti-tumor effects against the primary. So, therefore, the potential rationale to consider cytoreductive nephrectomy in patients who have outstanding responses. In my opinion, the future in the management of advanced clear cell and also non-clear cell renal cell carcinoma is bright. There are an increasing number of agents in clinical development, in preclinical development, and therefore this brings a lot of promise and a lot of hope for many patients and physicians treating renal cell carcinoma. What I envision in the future is that there will be a much closer interaction between medical oncologists specializing in renal cell carcinoma and a urologic oncologist or urologist who operate on renal cell carcinoma to both discuss in an interdisciplinary manner the timing, for example, of systemic therapy versus cytoreductive nephrectomy, and also the role, for example, of neoadjuvant therapies prior to cytoreductive nephrectomies, the role of adjuvant therapies in certain cases, and there will be, and this is very exciting, there will be, in my opinion, much more interactions and much more interdisciplinary discussions of a number of patients with advanced renal cell carcinoma.